Yeah.
So the purpose of this video is to give a quick, easy instruction on how to reduce an ankle fracture. It's pretty much foolproof, and I get it, all ankle fractures aren't created equal. But when ankles fracture, and whether it's a bimalleolar or a trimalleolar, or whether it's dislocated or just subluxed or even not moved out of place at all, you can pretty much use the same maneuver to get them reduced. One thing I will just mention is that I know most people probably do procedural sedation on these ankles to reduce them. I've reduced a lot of ankles on my own in the ER over the years, and most of the time you can get away with a hematoma block and it does the job. Totally your choice. I just want to let you know that if you do that, that is an option. If a hematoma block is, if procedural sedation is not convenient or an issue for another reason, patient may be not amenable to that for whatever reason. So if you do a hematoma block, as a landmark, I would say, you can't really manipulate an ankle that's fractured, but usually you can, the EHL, the extensor tendon that lifts your big toe up, is the one over here as medial as possible, and it's usually very palpable. It's a huge tendon, and you can also kind of feel the medial malleolus even if it's fractured, and going in between there, in between the EHL, you can even go through the EHL, so that's not that big of a deal. But what you do is feel the joint, a 20 gauge needle, introduce it into the joint, kind of straight down into the joint. You can feel the medial malleolus right here, the EHL here. There's a soft spot right between them. You can aspirate, you'll get a flash of blood for the hematoma block, just like the wrists, and then go ahead and put in 10 cc's of whatever your flavor is, 1/4% or lidocaine, 1/4% marcaine or lidocaine. So, and then 10 minutes, let that set up, and a patient will, it's not pain-free, but it'll make it tolerable. So what I'll do is have you just roll that up above your knee. And so to reduce this, almost regardless of how the fracture is mal-reduced, or how it's displaced, or whether it's dislocated or not dislocated, this will work. Get a Curlix, simple Curlix roll. Unroll it, fold it in half, okay? Take that loop right there, stick it between the big toe and the toe next to it, and then just loop that over those two toes, okay? Pull it tight. And believe it or not, that'll hold. Those toes might turn red, they might even turn blue, but you're not doing this long enough for that to matter. You can put a tourniquet on for a couple of hours before. So then I take an IV pole, you're going to hang it. Now, this IV pole, I want to bring it back towards the patient's head, and on the opposite side, just like that, and then you can adjust it and bring it up if you want, but you want to bring it back up because you want to try to get this ankle at 90 degrees. Now, most dislocations, if they're dislocated, are going to be posterior or lateral. When you're pulling over here to the medial side, you're going to automatically reduce it over to, because it's pulling towards the medial. And if it's dislocated, the talus is going to be dislocated posteriorly. So hand on the heel, push right there, it's in. Half the time, by the time you pick this up, it's already done without even doing a reduction. So you may want somebody to just keep a foot on this so it doesn't roll or doesn't tip. And once you get it on there, do not, even if they're perfectly reduced, and they will be most of the time, worst case scenario, again, It's going to want to stay where it started. So once you get it there, it's going to want to stay there, especially when you're in this called the Quigley position, when you're in this medial side, and again, remember, up towards the patient's head so that this thing is back in dorsiflexion. This is where you put on your splint. It's easy. Okay. Take out your pre-cut splint. I use the 3x35, and I get 2 of them. If you go wide on a smaller patient like this, the 4-inch or the 5-inch, it's going to wrap around, and then you're going to get circumferential, and not kind of, and close that down and kind of put the potential of too much pressure if that swells more. So I use a 3x35 ace wrap. Don't use Curlix. Don't use those other anything else. Ace wrap has give to it, and don't do it tight. So take it kind of really. What you really need is the ball the ball of the under the little toe and the ball under the big toe. Those have to be covered. You don't need to go well beyond the toes. These are what's important. So if you're all alone, it's easy enough, and you shouldn't be all alone doing this, but you absolutely can be. So this is obviously going to be way too long. You do not want to come up here close to the knee, because when they flex, it's going to impinge. So just fold it over. Done. Now you got your posterior on. Yep, you could wrap it more, but you don't really need to. You're going to wrap again when you get the stirrup on. Take your other 3x35. Again, you don't want to be up here by the toes. Be back by the heel. That's where you're providing the stability. Any leftover, just fold it down. And then just let this, I don't have another ace wrap, but you can see and make it look pretty and put an ace around the whole thing. But you're in a dorsiflex position. If you need more dorsiflexion, go up closer towards the head. And then let this thing harden before you take them out, because that's where you're going to lose your reduction. So let the splint get hard. These toes, you see this is turning a little bit purple. It's absolutely fine. Again, it's a tourniquet. That is, you're not going to do damage to those toes. And patients, believe it or not, tolerate this really well. So you wait till this gets hard, and once that's completely hard, pop it off. You're done. It's going to be well reduced, and it's going to stay reduced. That's it. Pretty straightforward.